In Module 6, we will talk about the management of infant with established BPD. Of course, we will not have enough time to cover the management of BPD in detail. Therefore, the learning objective of this module will be to understand the overall principle of managing BPD and some general approaches to nutritional support, respiratory management, and pulmonary hypertension treatment. You will also be able to describe the benefits and limitations of commonly used medications for the treatment of BPD. Based on the pathogenesis and the multi-system problems of BPD that we have reviewed in the previous modules, the overall management principles for infants with established BPD should focus on promoting normal lung growth and injury repair while preventing further lung injuries. The ultimate goal is to improve the overall health and neurodevelopmental outcomes of these infants. Several aspects, including optimal nutritional management, appropriate respiratory support, pulmonary hypertension treatment, and proper use of medications, are very important in achieving these goals. We will discuss these further in the next few slides. Unfortunately, data regarding optimal nutritional interventions in patients with BPD are limited. However, the current data do support that the nutritional management goal in this population should be to deliver adequate nutrients that match each patient's specific needs, so that to promote a pro-growth state and achieve proportional growth. Linear growth has been associated with lean body mass accretion and organ growth and development. We therefore emphasize on proportional growth with target weight for length ratio of 50%. These nutritional goals can be achieved through weekly titration of nutrition with the help of dietitians who are familiar with this population, and minimizing stress through non-pharmacological support instead of just pushing up calories. One of the most important aspects of this support is providing adequate respiratory support. This is not just to keep the blood gas in the acceptable range, but means adequate support that allow the babies to grow and to participate in developmentally appropriate activities. Chronically elevated work of breathing can worsen GE reflux that commonly seen in premature infants with BPD. It also affects the infant's ability to coordinate suck, swallow, and breathe during oral feeding. GE reflux and poor oral feeding lead to increased risk of microaspiration and further pulmonary injuries. Secondly, significant work of breathing increases calorie expenditure, resulting in poor growth. When caloric density is increased without providing adequate respiratory support, weight gain may be achieved without meeting goals for linear growth, which correlates with organ growth, including lung growth. Additionally, provision of increased caloric density increases the respiratory quotient and may adversely impact work of breathing. And third, episodic hypoxia events can be detrimental to BPD patients. These events can lead to pulmonary vasoconstriction and contribute to the progression of pulmonary hypertension. Providing adequate respiratory support is essential on breaking this vicious cycle of chronic respiratory insufficiency and BPD. In daily practice, providing optimum respiratory support to patients with BPD is actually hard to achieve, as the need of each individual patient is different. Good understanding of each patient's pulmonary mechanics and decide respiratory support accordingly may be the most effective and safest way of providing good support while minimizing further injuries in these patients. For example, we have discussed the pulmonary mechanics in patients with heterogeneous lung disease in Module 4. In summary, these patients have uneven ventilation with fast and slow compartments throughout their lungs, and increased dead space either from atelectasis or cystic changes. A good ventilator support strategy from this type of patient would be the two-compartment model to adequately support both the fast and slow compartments. Slow rate with longer vent breaths, inspiration time, would enable sufficient inspiration and expiration time for the slower compartment. Large tidal volume and adequate PEEP helps to overcome increased dead space, maintain FRC, and avoid expiratory airway collapse. In addition, high enough pressure support during which time the patient determines their own I time will further improve patients' comfort and decrease work of breathing. However, this type of ventilation strategy does not fit every patient with BPD. A patient with unified lung disease and diffuse alveolar simplification might like faster rate with short inspiration time and lower tidal volume ventilation. This type of pulmonary mechanics-based ventilation approach has been used in several centers with success. However, there are variations in details among the centers, and this approach has not been systematically studied. Well-designed multi-center studies are needed to guide best clinical practice. As all of you know, pulmonary hypertension is an important comorbidity of BPD, and appropriate management of pulmonary hypertension is extremely important for the overall outcome of the infants with BPD. Here, we will not have time to go into details of pulmonary hypertension management. However, understanding the general principles of pulmonary hypertension treatment is very helpful. There are three main components of pulmonary hypertension treatment strategy. They are 1. To decrease pulmonary vascular resistance, 2. To promote growth of the lung vasculature, and 3. To prevent right heart failure. To achieve any of these components, the most important thing to do is to provide adequate support to these infants first. This means adequate respiratory support and good nutritional support. Without a well-ventilated lung and healthy growth of pulmonary vasculature, simply putting the baby on multiple vasodilators will not help, and sometimes can cause more hypoxemia by worsening the VQ mismatch. This graph demonstrates the currently available vasodilators that are commonly used in the treatment of pulmonary hypertension. These medications work through three major pathways, that is, endothelin pathway, nitric oxide pathway, and prostacyclin pathway. However, the benefit of early vasodilator treatment is unclear, and there is minimal data on use of pulmonary vasodilators in neonates. Because there's limited literature on the safety profile of these medications, especially with combination therapy, pulmonary hypertension-specific drug therapy should be guided by a pulmonary hypertension specialist. Medical therapies such as diuretics, bronchodilators, and corticosteroids are frequently used in conjunction with respiratory support modalities in infants with BPD. Unfortunately, randomized controlled trials in this population are sparse, and definitive evidence of efficacy and/or safety for many of these drugs is lacking. This slide lists some potential benefits and concerns for these medications. Among these medications, systemic steroids use for the treatment of BPD has been the most controversial, mainly due to concerns for increased risk of neurodevelopmental impairment, particularly cerebral palsy. Recent meta-analysis data by Doyle et al. Suggests that the adverse long-term effects of dexamethasone when used in the first week of life and in infants at low risk for BPD outweighs its benefits. However, among infants who continue to require invasive mechanical ventilation after the first couple weeks of life, the balance may favor the use of corticosteroids. Importantly, the optimal dosing regimen and timing of initiation for prevention or treatment of BPD have not been determined. This concludes Module 6. Thank you for your attention.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.